Welcome to the Weiser Center for Prostate Cancer, a sanctuary for hope where you and your family can thrive, from diagnosis through treatment, with patient-centered care from our team of experts and the wisdom of advocates and former patients.
We help patients understand what treatment looks like, what their treatment options are. We provide guidance. We want them to make the best decision for themselves.
A very common question that almost all patients ask are, if you were me, doc, what would you choose? It really depends on what each individual's personal values and preferences are.
Different patients emphasize things differently. Some might emphasize a particular side effect. Some might emphasize how likely there is to be a cure. Or some might emphasize the likelihood of avoiding any residual cancer after a treatment.
Some men have strong personal biases towards an individual treatment. And given that treatment is equally effective with surgery or radiation therapy, we always recommend that they go with their preference. I meet many men who tell me, why would anyone ever have radiation therapy? I'm going to have surgery. And I support all of those men in their decision. Conversely, I see men who say, why would I ever have surgery if I can have radiation therapy? And we support those men in their decision.
Of course, one of the most common questions we get in the clinic is, I've heard what you have to say about the different pros and cons of each treatment, but which is the best one for me? The challenge is that there is no one size fits all. It's different for every patient, and it should be different for every patient because everybody has different priorities in their lives. And so for some patients, their urinary function, and for another patient, the risk of erectile dysfunction with treatment is a really important priority. We often will have very specific recommendations. So, for example, a patient who has really early stage, low risk prostate cancer, we're likely going to recommend a management strategy called active surveillance. And for another patient who maybe has cardiac risk, we might recommend radiation rather than surgery because of the increased risk that surgery might pose for them. They're important conversations for us to have in the clinic, but a lot of what we're talking about is going to be tailored to the individual preferences of a given patient.
When choosing a treatment option for newly diagnosed, clinically localized prostate cancer, there are several items to consider. One, of course, from a global perspective, is the patient's age, other medical conditions, past surgical history, any traumatic history to the pelvis, any certain conditions that might predispose them to bleeding, some pre-existing lung condition, heart attacks, strokes, patients on dialysis, patients with severe neurological disorders, bad, poorly controlled diabetes. Cancer-specific items that we normally consider are things like the Gleason grade, the microscopic assessment of how aggressive it is, the stage of the disease, meaning how far the cancer we believe may have spread from beyond the prostate to points elsewhere in the body shape, body habitus, relevant conditions that are affecting the colon. All of these things factor in for any surgical procedure, as you might imagine, and there's certainly weigh into our calculus about whether a patient would be an appropriate candidate for surgery or not.
And so what we do is we work together. We try to figure out what the patient's perspective is, what their values are, and then myself and the urologist get together and figure out what our perspective is, what we may think is the best treatment for them. Well, maybe it's a gut feeling. Maybe they lean towards surgery, or maybe they lean towards radiation therapy. They may ask their family, they may ask their friends, they help guide them through the pros and cons, make a list together of what the right things are that are important for them. Oftentimes people may focus on logistics as well. What are my downtime away from work? How many times do I have to get away from my friends and family? How does that work with trips and vacation? And we really want to make sure that we give the best treatment that works for the patient's individual circumstances.
In some sense, you can't make a wrong decision between surgery and radiation therapy. They are different logistically and side effect profile, but with modern treatments, most men do really well with either approach. For men with prostate cancer, there are three main treatment management strategies: active surveillance, surgery, and radiation therapy. Depending on how aggressive an individual's prostate cancer really drives which of those strategies we recommend. For men who we are recommending treatment for, the only two treatments that we typically recommend are surgery or radiation therapy.
Treatment decisions are really totally built around how risky that prostate cancer is. And so for patients with low risk prostate cancer, almost universally, the standard recommendation is something called active surveillance. And so not every prostate cancer needs to be treated. And in fact, the harms of treatment outweigh the benefit of treatment really by a long shot. Up that risk stratification scale to a category called intermediate risk or something called high risk prostate cancer. These are prostate cancers that really do need treatment. And the types of treatment that we have range from radiation to the prostate to radiation plus a medication called androgen deprivation therapy. And that's a hormone hormone blocker that blocks testosterone, so it's combining a medication with radiation, to another treatment called a radical prostatectomy, so that's a surgery that we perform, a robotic surgery to remove the prostate. Other treatments like something called prostate ablation or focal therapy, and that's a way of just trying to target a single area within the prostate where the cancer is, and that's a newer treatment that really is less commonly used, but is one that we do offer here for the right patient who maybe has a single, very small spot of early stage prostate cancer. Guiding patients through these decisions is what we do when a patient comes into our clinic, is go over the different risks of each treatment, the impact that any treatment can have on quality of life, and then the benefits that the treatment can have in terms of cancer control or cancer cure. When a patient undergoes surgery, they're usually in the hospital for one night, although increasingly patients have been able to go home the same day, particularly if they live nearby the hospital.
The Da Vinci or robotic prostatectomy for the treatment of clinically localized prostate cancer is typically comprised of approximately 5 incisions about 1 inch in length. There's usually 1 above the belly button, 2 to the sides, 1 below and 1 above. The surgery usually takes about 2 or 3 hours to perform and is done under a general anesthetic, meaning you're completely asleep. During the surgery, we remove the entire prostate and the ravida or structures behind them called the seminal vesicles.
Patients will have a urinary catheter in their bladder for 1 week. When that catheter is removed, most patients will have some degree of urinary leakage. Often it's 2 or 3 pads a day would be pretty typical, and we expect that incontinence to gradually get better over the course of about 6 weeks to 6 months after surgery.
Some men experience more or less urinary incontinence. It's best to anticipate that some of it will happen, and it's just not clear how long this is going to take to resolve. As many as 97% of men recover bladder control by the end of the first year after surgery, but the return to control varies depending on the extent of the surgery, whether there are any pre-existing urinary issues, and engagement in rehabilitation. All men in our program are sent to pelvic floor rehabilitation, which is a way of training the muscles of the pelvic floor to help control the flow of urine. So urinary incontinence for most men is a temporary, frustrating problem, but eventually improves quite significantly.
Initially, when I see patients, the goal is I need to get this cancer out, I need to get this treated, I want my life saved, and then followed by sexual side effects.
One of the other important risks of surgery is the risk of erectile dysfunction, and the reason for that is that the nerves for erections run right alongside the prostate, almost like an orange peel around an orange. For patients with prostate cancer that is really contained just to the prostate, we are able to preserve those nerves, performing a nerve-sparing radical prostatectomy. But even so, those nerves are like as fine as a spider web. The smallest bit of manipulation to leave those nerves behind, it does leave them stunned. Even if those patients have really excellent erectile function right before surgery, the vast majority of patients will have at least some degree of erectile dysfunction after surgery. And we have this program we call penile rehabilitation. We really help patients regain their erectile function. And at least 50% of patients who undergo nerve-sparing surgery will regain excellent erectile function after surgery. There is a significant risk of prolonged or even permanent erectile dysfunction. Now we have treatments like Viagra or Cialis, many more treatments that we can use, but it is a really important piece of kind of the prostate cancer puzzle for patients to be aware of.
With the loss of the prostate, the man loses semen, so there is no longer ejaculation, so orgasms are dry, but orgasms are still there. So the man is still able to experience an orgasm, but it is dry. Some men experience weakened orgasm or maybe even pain with orgasm initially, and that tends to improve with time and with stimulation. We have specially trained nurses who educate all men about penile rehabilitation and about aids to erectile functioning. And we also have the services of a certified sex therapist who helps men and couples with navigating their sexual recovery. Keep on reminding yourself that it's a process and that if you're not perfect quickly after surgery, it doesn't mean you won't get better.
The penile rehabilitation includes multiple pieces to try to prevent that scar tissue from developing. If you develop that scar tissue at the base of your penis, your penis can shrink. You can have problems with erectile function. You can also develop peyronie's, which is a curvature of the penis. We want to get an adequate blood supply because what scar tissue is a lack of blood supply. That's why it develops. So we want to make sure we do that. And we'll talk about more information after the surgery because right now you're overwhelmed. Thinking about surgery versus radiation therapy, you're overwhelmed. And so we don't want to give you too much at this point. But you know that penile rehabilitation is very important for your long-term recovery.
A special attention should be paid to this recovery process by men who practice anal sex, simply because, number one, the prostate is no longer there, so the sexual stimulation and the sexual pleasure that comes from the prostate is no longer available. But also because surgery occurred in the pelvis, everyone who practices anal receptive sex should be discussing with their surgeon how much time is necessary for the healing of all the sutures inside to be able to comfortably and safely practice anal sex again.
Patience and perseverance are very important. It can be a long process, but there is hope.
Radiation therapy can come in several different forms, but the most common form is high-energy X-rays coming from the outside. So they treat the cancer from the outside in while the patient is awake. It does not involve any anesthesia or any procedures. Most of our treatments are delivered with a linear accelerator, and that simply means that you lay on a table in a room. The radiation is aimed where the prostate is. What we try to do with the prostate cancer is aim the radiation at the prostate and avoid as much of that sexual function tissue as we can, similar to nerve-sparing surgery. But oftentimes, men, particularly those that are healthy and have good function going into the treatment, may continue to have sexual activity in a similar way that they did beforehand.
There are types of radiation that can, where the treatments last a few minutes, 5 days a week for several weeks, and there are other treatments that are only last a few minutes and they every other day for about approximately 2 weeks, so really about 5 treatments only.
And often men are surprised with radiation therapy how much they can continue with our current activities. We have men that work during treatment. We have men that continue to golf during treatment. We have men that continue to care for their kids or grandkids during treatment, being able to do the things that are important to them.
Radiation is interesting. It's not something you can see, smell, or feel, and the radiation is given. It usually takes only a few minutes, and a patient can drive themselves to the radiation therapy and drive themselves afterwards home or to work or to have lunch or do whatever it is that they have planned during the day. And importantly, prior to radiation therapy, there's 2 main things that are often done. The first is the placement of what we call fiducial markers. These are small little gold seeds, typically 2 or 3, that a urologist places both within and around the prostate. The machine can triangulate on the precise, exact spot that needs to be treated. The urologist, at the same time that the fiducial markers are placed, injects in the perineum. This hydrogel acts as a cushion and really helps shield the rectum from negative side effects of radiation to the rectal area. A lot of the rectal side effects that patients used to have before have really gone away.
Radiation therapy can have many impacts on an individual patient's body. When men are undergoing radiation for prostate cancer, there are 3 common side effects that they may notice as treatment progresses. Those are urinary side effects, bowel side effects, and tiredness or fatigue. With all 3 of those side effects, those typically gradually progress over the course of treatment and are most noticeable at the end of treatment or even a week or 2 afterwards. From a urinary standpoint, we expect men to potentially develop a weaker urinary stream, to urinate more frequently, occasionally have some urinary urgency where men feel like they have to get to the bathroom faster than normal, and occasionally men will also have some burning or discomfort with urination. With regards to bowel movements, men may notice a change in consistency in bowel movements or have softer or more frequent bowel movements, and occasionally this will progress to the point of diarrhea. Men also will have some tiredness or fatigue associated with treatment. This typically is not a tiredness or fatigue that prevents men from doing what they want to do in the course of a day, but most men tell me by the end of treatment, by 4 or 5 in the evening, they feel like they are dragging more than normal. Long-term side effects are much less common with modern radiation therapy, but tend to be more serious if they do occur. The risk of long-term radiation damage to the bladder or rectum is quite low. The risk of developing painful bloody urination in the long term or painful bloody bowel movements in the long term from damage to those organs from radiation usually would not be expected to happen in more than 1 to 3 men out of 100, so an uncommon side effect. In the long term, radiation can also cause erectile dysfunction. This tends to be a gradual decline in erectile function for men who have good function going in over the course of years. The best predictor of men who will have good sexual function in the long term is men who have good sexual function before treatment. For some men who receive radiation therapy for prostate cancer, we will also recommend adding a course of an anti-testosterone hormone therapy with the radiation therapy. The duration of this hormone therapy varies based on the aggressiveness of an individual's prostate cancer, but typically may range somewhere in the ballpark from 6 months to 2 years. The reason that hormone therapy is given with radiation therapy and not surgery is that hormone therapy actually sensitizes prostate cancer to radiation and makes the radiation more effective. And this has been consistently demonstrated in very large clinical trials performed all over the world.
And whereas radiation doesn't tend to have immediate big effects on sexual function, the hormonal therapy tends to lower testosterone. And by lowering testosterone, oftentimes that can affect the sex drive or affect the libido. Oftentimes we stop the medication as part of the treatment, allow the testosterone to recover, and then that's when the men see their libido or their sex drive recover after treatment. And particularly when receiving radiation therapy alone, there's no restrictions on sexual function. They can participate in sexual activities. So we encourage patients to ask and ask often. We have many medications that can help in various situations. So the first question that many men may have as they're undergoing radiation therapy is, am I radioactive? Do I have radiation in my body? You're not radioactive during treatment. There's no wrong question. It's important to be open with your provider, open with us of your worries and concerns of how this may affect you, yourself, your bodily functions, as well as your intimacy with your partner.
And so our jobs as physicians is really to help educate patients so that they're able to make the treatment choice that is right for them.